Hello and welcome to the Best of the STFM Conference on Medical Student Education webinar. My name is Emily Walters. I'm on staff with STFM and I'll be facilitating today's webinar session with our panelists, Dr. Florio Pipas and Dr. Roberto Montenegro. We're so excited to have you all here today. We have wonderful presentations planned today with Dr. Pipas, who gave the presentation at our 2018 MSc conference, the Conference on Medical Student Education, and Dr. Roberto Montenegro, who is going to give our presentation at the 2019 conference, which is coming up here next February. We are pretty excited about this coming presentation, and we're so glad that you're all here and with us today. So just glad that you're all here, and I'd like to invite the audience to use the webinar chat box at any time to submit questions during the webinar. We will pause to answer your questions, and so I want you all to know that you have that option. You should see a little question mark, and you can use in your webinar chat box, and you can use that to submit your questions, and I'll be able to, once our panelists have concluded their presentations, there'll be set aside time for Q&A at that point, and we'll be able to get to your questions. I also want to let you all, we kind of want to know who's here today, since this is a webinar for presentations for this Conference on Medical Student Education, but we also have advertised this to our entire STFM membership. We're curious about who's here today, and so we'd like to run a live poll to find out. And so I'm going to go ahead and activate that poll to find out what is the best way, which of the following best describes your professional role. All right, so I'm going to give you just a little bit of time so that you can choose which best describes you. If you are a student, a resident, medical school faculty, residency faculty, or other medical educator or practicing clinician. And we do realize that there are a lot of people who are members of STFM who work at both medical schools and residency faculty as well. All right, so the votes are coming on in, and I do appreciate the time, so I'm going to go ahead and close the poll and share these results with everyone. Okay, so it looks like we've got a good representation from students. We're so glad that you're all here with 7%. We've got medical school faculty as well, residency faculty, and quite a few who identify in the other categories, medical educators and as practicing clinicians. Okay, that's fabulous. We're so glad that you're here today. I'll go ahead and hide the poll. And okay, wonderful. So without further ado, I'd like to go ahead and introduce our first presenter, who's Dr. Florio Pipas. Dr. Pipas is a professor in community and family medicine at Dartmouth's School of Medicine, where she directs the Culture of Wellness and Leadership curriculum. She is the author of a new book, The Doctor's Dozen, 12 Strategies for Personal Health and a Culture of Wellness, which is pretty exciting. It just came out this fall. She has been recognized as a leader in education, research, and clinical care with awards including 2017 and 2018 New Hampshire Top Doctor, Dartmouth Medical School Master of Educator, Clinical Teacher of the Year, Humanism and Medicine, and the AOA Honor Society. Dr. Pipas serves on the Board of Directors for the Society of the Teachers of Family Medicine and the Administrative Board of the AAMC Council of Faculty and Academic Societies. And without further ado, Dr. Pipas, I'd like to go ahead and turn it over to you for your presentation.
Thank you, Emily. I appreciate your logistics expertise. And I believe I am on. So good afternoon, everybody. I am thrilled. It's really a pleasure to be invited back to share what I've learned around my own journey towards personal health and this path that I've been taking to support self-care in others. I have been at Dartmouth about 25 years now in multiple different roles, as Emily shared, and really, in the last probably decade, my work around personal health and creating cultures of wellness has been probably some of the most rewarding work that I've had. And that's really for a couple of reasons. First, it really challenges me on a daily basis to walk the walk and to be able to do what I'm asking of my patients myself. Secondly, it's really been a wonderful opportunity to collaborate with colleagues like yourselves who are really eager for both the time and the tools, as well as the permission for all of us to create cultures of wellness. And then lastly, it's been a wonderful opportunity to begin to build a strong business case for us to recognize the value of putting health back into our health professionals and to promoting health within our own healthcare systems for ourselves as providers as well. So I'm thrilled that STFM has prioritized this topic, and I'm very grateful to Emily and all of the leadership at STFM. And I'm also very grateful to you. And so I want to thank you as an individual, not just for your commitments to caring for your patients, but for your commitment to caring for yourselves. And so I'm going to ask you to take 1 second and turn to the person next to you and thank them for the care they provide for themselves. Now, I can't see you doing this, and if you happen to be in a room that you're by yourself, then I'd like you to say out loud, "Thank you for taking care of myself," to yourself. I'll give you 1 second. Excellent. So again, the priority here is really focusing on how do we care for ourselves in order to provide better care for others. And the objectives that I'm going to cover. Oops,
I'm so sorry to interrupt. I know you're, this is wonderful, but we're not yet seeing your screen. It looks like we're still waiting to view it.
Not seeing my screen, okay.
Slides.
Let's see. I have, is the screen to me?
Yes.
Okay.
It looks like it's possible that it's paused. So we can switch off, and I might pull it back to myself for a second here, and then we can switch it back to you. Does that work?
That's fine.
And then here we go. And it should give you that option to show your screen. There we go. We're up and running.
Okay. So are you on my slide set? Are you able to see the objectives?
Perfect.
Okay. So the three objectives are really to just talk about the importance of self-care and the impact of burnout, and then briefly to describe some of the factors that threaten our health, both individually and as an organization. And then we're going to have some opportunity to explore some of the evidence-based strategies. And my hope is really, I'll share a little bit on the data of the slides so that everybody is on the same page with what we already know, and then focus about half of the time really on some of my own research and looking at the question of what can we do about the challenge that we're facing. And so, let's see. Okay, so this is really the core premise to everything that I have been focusing on and learning. Really, the idea is that my own health is critical to my effectiveness as a blank. And you can fill in the blank for yourselves. For myself, it would be as a mother, as a wife, as a physician, a clinician, an educator, a researcher, any area that I'm working on. And really, this can sometimes be a paradigm shift from some of the things that I know I've been trained to think about what our ability is to collectively care for the populations of patients is not just dependent upon our ability to provide good care to others, but really dependent upon our ability to care for ourselves. And so when I use the term health and wellness, I just want to share one definition here to be thinking of this similar to ways that the Institute of Medicine defines wellness, much broader than the absence of illness. And so with my clicker, I'll just walk around this. And the idea is that when I talk about wellness and health, I'm thinking of it very broadly to use any one of these this is a particular scale from Vanderbilt. So the idea that it's not just our physical health, but our overall wellness incorporates and includes our social health, how we network with other people, our spiritual health, that sense of purpose and belonging to something larger than ourselves, our occupational health and the balance between work and outside life, our environmental health, both in the natural world as well as the culture that we work and live in. our intellectual, in terms of our stimulation. And then lastly, which for some, and myself included, is often the most challenging, this is our emotional or our well-being in terms of how we're feeling. And so these are all of the ways that we're defining wellness and overall well-being. And so it's quite comprehensive, and it can include and should include all of these areas. So the data begins in 2011 in many ways with this kind of sentinel article per Tate Schonefeld looking at burnout. And it looked at it over 2-year period, over 2 time points from 2011 to 2014. And what we know is that burnout in the general population is nearly 30% or 28%. So the general population of people was steady over that time. But in essence, 1 out of every 3 people that work in our country reports being burned out, which is not really acceptable. But unfortunately, it's even worse for physicians. And we've gone from about 45 to 54% during that same period of time. The flip side is the satisfaction with work-life balance, and roughly 60% of the general population reports being satisfied with that balance, whereas physicians are significantly lower and falling. And the data beyond this is the same for whether we're looking at burnout in medical students, residents, our nurses, our clinicians, researchers, pretty much all levels of health professionals are significantly above the general population. Another thing we know is that medical students, which are in red here, compared to their pre-med peers, have a greater sense of quality of life, both mental, physical, and emotional. They also have lower degrees of burnout and depression prior to starting medical school. But as soon as that they enter our world, our environment, that changes. And so a lot of this begs the question of what's happening in our environment. Another thing that we know is that education is protective against burnout. And so when we're comparing any of these with degrees to high school graduates, particularly bachelor's degrees, we have 20% less likelihood of burnout. A master's degree with an odds ratio of 0.7, 30% less likely of burnout. And a doctorate degree is 40% less likely for burnout. The exception to that is the MD and the doctorate DO degree, which is roughly 40% more likely to have burnout. So again, we're begging the question is what's in the water in essence? When we look at the same period of time and we look for the specialty, which students are often asking me that's immune to this, none of them are. And the thing that stands out in this period, this data set, is that all of the disciplines increased over that same period of time from 2011 to 2014. And unfortunately, family medicine is right there near the top in number 4. When you look at the most recent 2018 data, unfortunately, we've gone up to being number 3. But there's really no specialty that's immune from this process and immune from this challenge right now. The other thing that we know is that when we look at physicians who are potentially very knowledgeable, very skilled in assessing burnout in others, we do not reliably assess it in ourselves. And so that's a combination of things that lead to a challenge. So one of the things that we're often saying is, well, what does burnout look like? How do we be sure that we do know what it when we see it in others and ourselves? And we can compare it to somebody who has well-being, in the sense this is a new employee that might come into a job and very excited, cares about others, volunteering to do things, engaged in processes, as opposed to when we're seeing somebody who, in essence, in one word, you could say they really don't seem to care. And they may be irritable. When I see a colleague who's a little bit irate or unprofessional, I now am more likely to ask myself, are they actually burned out, rather than seeing it's just somebody who has a personality issue. They become disengaged. And in somebody who's being reviewed, like a student or a resident, we might actually see the first sign of burnout as a poor performance, where somebody is not actually performing to their levels that they previously were. So a lot of this is really, it can be masked in many different ways. And so one of the questions around burnout is really, there's 22 items on the scale that's most commonly used by Maslow, but the one question of, are we burned out from our work, is sufficient and sensitive and specific enough to be a screener for asking about burnout in ourselves. So the data that continues to surface right now is telling us that we have enormous amounts of knowledge And we know that burnout affects the individual who's burned out. So if I'm burned out, my own satisfaction is down. I have a lot of both physical as well as emotional challenges. I may be displaying unprofessional behavior and a much higher rate of both depression and suicide. In my own experiences, unfortunately, I've had medical students in my medical school class, in my residency, as well as physicians here at Dartmouth since I've been practicing that have committed suicide. We also know now that burnout is impacting our organizations, and we're looking clearly at the data that's showing an increased cost to organizations. But what's been most impressive and I think most startling is that we're now seeing data that shows if I'm burned out as a professional, my patients are being impacted, and we're affecting the quality of care that we're delivering. And overall, this is causing a public health crisis that really is demanding our attention. And so it begs the question of why, and we can think of this on a lot of different levels, but most of the questions that we're asking are both at the individual level. What are the things that are contributing to my lack of wellness, if you will, from an individual perspective, and what are the things that are from the institutional perspective? And most of the debate on both sides, it says that there's factors on both sides. And when we think about these, this is just a way of looking at this from our beliefs. What are the things that we come into medicine thinking? What are the things that we buy into in the culture of medicine when we've entered our profession? But things such as self-care being a stigma, and that it represents weakness, or that we're invincible. And what are some of the personalities? And again, in the workshops that we've done, we're looking at these and saying, you know, we are perfectionism. We're perfectionists, and that can be a big strength, but it can also be a challenge in an area in terms of being able to take time off to take care of ourselves. Some of our behaviors in terms of working, not taking breaks, and potentially being in isolation can contribute to that. We also know some of the things about our own culture in medicine, the do more culture, and unfortunately that's not just in medicine, but overall in society. We also have a lot of challenges within our programs, and this includes our excessive and workloads, as well as inefficiency in some of our workflows. And we've got policies that still continue to drive. Many people are blaming the EMR as a whole, but that are mission driven, that are not mission driven, rather that are actually driven by RVUs, and that are limiting our vision. And so when we think about how to change things, it's helpful to ask some of these questions to really be able to address this from a framework of improvement. And so once we're identifying what the problems are, we can take the same process that probably many of you are familiar with to improve systems, awareness, systems care, and systems improvement, and we can apply this same framework to self and team awareness, self and team care, and self and team improvement. And this is a lot of the work that I do in this area, is to understand what's happening at the level of either the individual, the team, or the system, and how to make those rapid PDSA, plan, do, study, act changes. And so I'll just highlight a few of the summaries that are coming out. There's lots of data that's surfacing, and there's lots of resources available right now trying to share those, in addition to having so many schools that are being charged with making changes. And I've been working with a lot of schools around the nation, many of which are having medical school committees on wellness, residency-based committees and programs for wellness, hospital-based, employee-based, physician-based, faculty-based. And so the literature is really supporting, we need to address this from all angles. We need to have strategies that are organizational based, that are team based, and that are individual based, so that we're not looking at only one angle when we're trying to overcome this challenge. I'll just share this one article looking at the organizational approach, and Tate Schonefeld again has charged us, and he is the CWO, or Chief Wellness Officer at Stanford, previously at Mayo Clinic, and he has charged us with making sure every organization has a comprehensive approach to wellness for their employees, similar to what many organizations outside of healthcare already do, but that this is part of the core strategic planning. We're using the quality improvement framework. We have a Chief Wellness Officer, or at least a leadership team, looking at this, and that they have broad goals that include the health of the employees, i.e. all of the health professionals, but that the organization allows the interventions to be decided at the individual level or the frontline level. That there's policies, if you have a residency and a student wellness committee that those policies are working collaboratively, and that we have metrics and we can measure some things going forward and look at outcomes in a longitudinal way. And that, very importantly, he's one of the first to point out that we need return on investment resources. And he puts some dollars to this, showing that we're losing roughly $6,600 per physician per year that's burned out. And his proposal is that if we even took just 10% of that funding and reinvested it into wellness, then we would be having a long-term benefit. And so again, also the need for research and education continuously. So yes, we need to look from the organizational level. There's also many interventions that are happening at the team level, and many looking at that organization and team time. How do we make sure that we have the teams working together effectively, and particularly everybody working to the top of their license? There are programs looking at MA's roles, both in scribing and also at decreasing regulatory burden, things that will not affect our patient care directly, but are really time consuming. Most of what we are finding as challenges are people not having autonomy and having many burdens in policies. The ACGME is also looking at requirements, and they've not been as specific, but they're saying we need to have common program requirements for every resident now, identifying this. And I love the quote by Tim Brigham, says, "We need to protect the workforce that protects our patients." Very similar to the words and the message from Tom Bodenheimer, who says that we'll never be able to achieve our triple aim if we're not doing what he calls the quadruple aim. If we're trying to provide better care, better health, and lower costs for patients, but we're doing so on the backs of our providers and our healthcare teams, we're never going to succeed. And so there's also been a lot of efforts around educational strategies, primarily looking at ways to decrease high stress situations and making sure we have good access to mental health, that stigma is addressed, that we have things in the classroom, pass fail, and we also have specific wellness programs at the medical school level. So one of the areas that I've been continuously looking at, and this challenge has been that we don't have enough educational research. My own research has been around identifying what are the evidence-based strategies for personal health and cultures of wellness in both the individual and the research organizational level. And so at Dartmouth, we ran a culture of wellness pilot, and I've been working with other schools to run similar pilots. And in our case, we chose to do this with students and faculty jointly. We looked at different metrics, which I think are critical that we start to look at those similarly, but we looked at metrics around burnout, we looked at metrics around quality of life, perceived stress, and overall mindfulness. And we use the same ones that the AAMC is proposing for students throughout the 4 years of medical school. And we provided, again, a very brief 12 hours for 12 weeks, tools, which were evidence-based cases, and then that collaborative permission to discuss the topic and to look at joint interventions that might be helpful. So the work that I've been doing has really been in researching what are the evidence-based strategies. And as Emily mentioned, my book that I just published is called A Doctor's Dozen: 12 Strategies for Personal Health and a Culture of Wellness. And it reflects the patient care that I do, because each of the 12 strategies is illustrated by a patient's story. And it's really broken down into the same quality improvement processes and 3 areas of self-awareness, self-care, and self-improvement. And it is really basically a curriculum, because I have used this. Each chapter has the ability to serve as tools, and it has healthcare exercises that you can place and apply in your own areas. So the SWOT is a general tool that I think many people have used. And what I encourage people to do is to think about yourself using a SWOT tool rather than just an organization. What are the strengths that you have, the weaknesses, the opportunities, which are things that maybe excite you, and threats are things that really turn you off. And one of the curriculum items that we've been looking at is how do you apply some of these strategies? And I'll just walk through, and if you decide you'd like to look at the SWOT at the same time I'm speaking, feel free to think about these yourself and how you might apply these in your own lives. But the first strategy is around mindfulness and the idea of how willing are we to really observe and to slow down and see the life happening in the present moment and not multitasking. And again, you might think about where this falls. Is this a strength of yours already? Is it a weakness? Is it an opportunity, or perhaps something that you're not really interested in doing? And you don't have to have all of these strategies, but many of them can serve as resources. The next area is around self-reflection. And again, how comfortable are we listening and not necessarily always having the answer, but really just asking questions of ourselves and others. The next area is really resilience. And I know a lot has been done on this area, but how comfortable are we with challenges and thinking of them as opportunities to learn and to grow? The next area is self-reflection, or excuse me, narrative writing. And again, the idea of how skilled am I in journaling and interpreting my experiences. Next is really the idea of being committed to our own physical health and nourishing our bodies, exercise, and diet. The next area is on social relationships, and we can assess ourselves, again, how comfortable am I having a mentor and mentoring others, building trust and relationships. The next area is always a challenge, but time management, and particularly how purposeful am I in allotting my time, looking at both sleep and social media and all the things that I do with my time through the day. And the exercise there is to really do a time log and assess ourselves. The next area is around cultivating healthy environments, and this is really that how confident and committed am I to being a role model versus potentially shaming myself in an area where I'm doing self-care that may not be supported elsewhere. The next area that I've learned about, and again, the research is there for embracing change, not just in the logistical tools of improvement processes, but really the emotional change. And most change is resisted because of some fears, but how emotionally intelligent are we in particular? And the next is prioritizing purpose, again, finding that meaning, and how often do we make choices based on what things are most meaningful to us as opposed to saying yes to everything. And number 11 is really about cognitively reframing. And again, how flexible am I in my thinking, particularly if I come up with the words I can't, to reframe, put another lens on, and be able to get around that. And then lastly, appreciation and gratitude. And how often do I appreciate the progress that I'm making on something rather than waiting until it's completed or being dissatisfied overall? So one of the challenges I always say is to look through those areas, to begin to analyze your own strengths and to come up with some personal health improvement plans. And this is just an example of one that we've used in the groups that want to work together to reduce stress through mindful meditation. And they may be doing this through a SMART objective as a team or individually. We've developed some personal health improvement tools, and you can go onto the website and do those electronically based on some expertise from the students and residents I've worked with. And then I do have some additional resources for teachers and learners that are on the website where you can use some of the curriculum, and all of it's available. Please help yourself. I will stop at this point and take any questions. I think Emily's going to run that. I do want to mention we have a couple things coming up, the culture of wellness. We have a train the trainer at the next pre-conference at the 2019 meeting, and STFM has been committed to having this as part of faculty development delivered, and I welcome you to participate in the Culture of Wellness program. Emily, I'll turn back to you.
All right, wonderful. Thank you so much. Yeah, it's such a critical topic, and definitely STFM is very, very committed to this critical topic that we've heard so loud and clear is something that matters to our members, and that there are practical ways that we can address this both at a system level and at a personal level as well. So thank you for sharing those with us. I'd love to invite our audience to share questions that they have for Dr. Pipas at this time. So all of you, if you'd like to submit questions about perhaps how you'd like to implement this, or questions that you have about how to facilitate wellness at your own institution, you can go ahead and submit those through the webinar chat box, and we will be able to answer a few of those questions. Also feel free to, you can send additional questions to me since we are a little short on time. We'll kind of see what we've got coming in.
All that wellness in one nutshell.
Yes, absolutely. I know that's something that we definitely realize. These are little snapshots. This webinar session is a brief kind of highlights. Dr. Pipas is just hitting the highlights of what was a full hour presentation, and of course is an entire curriculum as well. So to be honest, for the interests of time, is there anything like, is there any one thing that you hear the most, Dr. Pipas, when you're just have people asking you kind of what is the number one thing? I mean, you have these 12 wonderful practical things, but what is it that you recommend to your students that is the number one thing that you see that they aren't maybe doing or should be doing?
Yeah, I think that whether it's student, resident, faculty, and actually everyone that I've worked with is really just taking the time to really know yourself. And I love that Aristotle quote that knowing yourself is the beginning of all wisdom. And we've been trained, much of our education has really been around knowing how to care for others and taking a step back from that and being committed to the concept that our own care will make us more effective at caring for others. It is not a sign of weakness. It is not a sign of laziness. It is really in order to be the best physicians we can be.
Absolutely. It's so beautiful. Okay, let's sneak in one more question. We have somebody who asked, one of our audience asked, have you found any physiological markers of burnout that we can measure and then evaluate to determine if we have helped with our wellness programs? It's an interesting question.
So I love the physiological questions. I'm not doing any research on that level myself, but there's absolutely a lot of studies that have been done saying that this is all related to chronic stress. And we know that stress in an acute sense actually makes us higher performers. And that scale goes up. The more stress we have, the better we perform to a certain point. And chronic stress, actually, we start to fall down. And so when we have all of the adrenaline, when we have the cortisol, when we have all the physiological processes occurring, we actually have that great sense of fight or flight, but we turn off some things in our bodies, and we turn off, not only digestive systems, but we turn off the capacity for learning. We turn off creativity. We turn off innovation. We turn off the cognitive higher functioning. And if we're under chronic stress, we're not going to be performing at our best. And so we need to be able to find ways to replenish. And the physiology is fascinating behind this. And I think that we probably only know the tip of the iceberg, but there's lots more to learn about chronic stress. And it is absolutely why this is happening physiologically. Great question. Thank you.
Yeah, absolutely. We've got some other wonderful, and that questioner says thank you. We've got some other wonderful questions coming in, but I do think we probably do need to move on, just in the interest of keeping things up for our other presenter. But thank you so much, and if any of you have any additional questions, do feel free to email me at, my name is Emily Walters. You can email me at ewalters, WALTERS @stfm.org, or feel free to reach out to Dr. Pipas as well with questions about wellness. So thank you so much. Now we'd like to go ahead and, so thank you. We'd like to go ahead and move on to, so we've looked back at highlights from our fabulous presentation by Dr. Pipas at our 2018 conference. Now we'd like to look ahead to our 2019 conference, which is going to be January 31st through February 3rd in Jacksonville, Florida. And at that conference, one of our closing session is going to be by Dr. Roberto Montenegro, who is here with us today. And so he's going to give a presentation. The title of his presentation at the 2019 Conference of Medical Student Education will be Addressing Microaggressions, Racism, and Discrimination in the Medical Workplace. Dr. Montenegro is a child and adolescent psychiatrist at Seattle Children's Hospital and the University of Washington School of Medicine, Department of Psychiatry and Behavioral Medicine. His research focuses on how perceived discrimination affects both biological markers and mental health. He also specializes in cross-cultural psychiatry, transgender mental health, social justice and health disparities, education curriculum development. And we're so excited to have him with us today, talking about such a critical and timely topic. He's just going to give a preview. He's got of course, this will be an entire hour-long session. And so once again, this is almost an impossible topic to crunch down to the tiny amount of time that we have for this session. But we still wanted to have this opportunity over the webinar to share a preview, snapshot of part of what he's going to cover in his 2019 session. So welcome, and thank you for being with us, Dr. Montenegro. I'll go ahead and make you the presenter so that you have the ability to share your screen.
Excellent. Well, thank you so much for having me. Let's see. Let me share my screen here. How's this looking so far?
So far, it hasn't popped up yet. Looks like we're still waiting to view. And there we go. We're all good.
Good to go?
Good to go.
Okay, great. Well, thank you so much for having me. It's an honor to be able to speak to great colleagues that are not psychiatrists. I appreciate you having an outsider here. So again, I think it's important for me to just emphasize that what I am trying to cover in 20 minutes is pretty difficult to do. I usually spend many weeks teaching this in medical sociology, so some of it will be brief. A lot of it you can get more details at the conference in February. So with that, let's get started. So 4 important objectives that I think it would be great to be able to discuss in these next 20 to 30 minutes is understanding the historical and sociopolitical origin of race and racism in the US and how it relates to at least 3 forms of racism. Now, in teaching about race and racism in medicine, we have really begun to see the importance of making sure that that students or the learners understand a bit more of the historical context of how race was created, so that when they apply it to the current understanding of race and racism, they have the important context of how it was both a social and political construct. Now, besides understanding the historical context of race and racism, we'll also be discussing how to recognize more subtle forms of discrimination known as microaggressions. And important to this topic as well is understanding some of the reflexive reactions that individuals may have, and particularly white individuals have, in terms of talking about race and racism, known as white fragility. And lastly, applying practical strategies for responding to and coping with microaggressions at both the individual and institution level. So moving forward with understanding the historical context, before we get to the historical context, these are some important definitions that we should all have in mind so that we can have the same language moving forward when we're having this discussion. Now, discrimination, as we all know, and as you know as primary care physicians, really happens throughout different systems on our day-to-day life. And each topic in this slide here is basic. There's there's literature showing evidence of how discrimination occurs on our daily lives, ranging from access to healthcare all the way to getting insurance to hailing a taxi. These are some of the key terms that I would encourage people to really get into the vocabulary. Now, and due to the time restriction, we won't be able to go through each of them, but understanding the concept of stereotypes, power, hierarchy, prejudice, bias, racism, and oppression are absolutely critical in terms of not only being able to address the experiences that a lot of your trainees or even yourself as faculty members may have at your institutions, but also just understanding the fundamental pedagogy of how to teach this material and how to understand it. Okay. So let's get a little more detailed about some of the historical context of race. So again, race is a socio-political construct that was really created and rooted in previous erroneous ideas that it's a biological trait. And it really was used to link individuals by made up, if you will, complex attributes. And so really to understand this, we have to first start shifting our paradigm in how we understand race and understand, again, it's a social and political construct based on arbitrary categories. And there is no biological or genetic basis to race. So the literature and genetic studies show that people are more common than not alike genetically. So race is an idea that was ascribed to biology, and it was really a tool that was used to describe individuals based on physical variations, and that can be used to justify social inequality and equity as being natural. So just because I'm saying, and the literature shows that race is not a true biological entity or idea, it doesn't mean that racism is not real. That's an important point to keep in mind. So how did we continue to perpetuate this idea of race and racism within the US? So it's important to understand the historical concept and how the European colonization plays a role in this. And again, we have courses that spend months teaching the context of the historical origins of race and racism in the US. So bear with me as I try covering a whole sociology course in 1 or 2 slides. So when we think of race and the rise of race in the US, it's an artifact of how Europeans used race to create hierarchy and justify slave ownership. Now, this concept was not only used in the US to justify non-European slave group ownership, it was actually brought from, some argue that it was brought from Europe in itself and how they justified slavery from Middle Eastern individuals as well. And so this was in the context of an emerging global economy, or the slave trade in Europe, that when Europeans colonized the US, continued to be perpetuated in our educational systems. Now, again, this was used to justify slavery of non-Europeans, and also embedded very tightly within religious, philosophical, political, and class-based, and back then arguably just biological justifications for racial oppression. And a good book to read on this history is a book by Ibram Kendi, Stamped from the Beginning, that I would highly recommend. So again, now we have an idea, a better understanding that race is not a biological truth. The idea of race and racism was brought from European colonization to justify oppression of other groups. So now to get a better understanding of how this applies to racism and how eventually this applies to us as physicians, I think it's important to understand the historical context of how identity shifts as well. So as many of you may know, the concept of race was perpetuated throughout history to continue to protect dominant power and privilege at the expense of the other group. So the concept of othering is a well-known concept within the social sciences. And so when we talk about othering or othering groups, it's really about boundary maintenance. And if you look at the historical context of US immigration and the identity of what it means to be white in the United States, you can see very clear boundary maintenance that many sociologists have written about for many years. So that looking back at the first settlers in the United States, we see that Native Americans and Mexican Americans have a very unique historical context. They were colonized by the white settlers in the 1800s. And African Americans also have a very unique historical context in the sense that many were forced through slave trade to come to the United States. So in terms of whiteness, if we look at how we have these groups, Native Americans, Mexican Americans, and African Americans, which have been abbreviated by NAMAAA here, we see that one of the first large immigration groups were German individuals in the early 1800s. And so Anglo-Saxons at that point had a view of anti-Catholics and anti-immigrants. So Germans at this point were not viewed as white. So then later in the mid-1800s, you have a high immigration of Irish and Polish. Irish and Polish at that point were not viewed as white individuals, but then they were created as the other group. So when the Irish and Polish were created as the other, then Germans became white. And along with Chinese, Japanese, and Korean, Filipino immigrations in the 1882 Chinese Exclusion Act, when this large influx occurred, they were viewed as the other. So then the previously other group, Irish and Polish, were now considered white. So now you have Germans and Irish. This pattern repeats itself throughout history, as you can see in this table. Currently, we find ourselves white and this very dangerous Asian model minority myth, which is a completely different lecture, and it's a very dangerous myth that attributes a lot of false ideas to certain Asian groups that can gives a false sense of being white. And again, we have the other group now, currently Latino, anti-Muslim, Native Americans, and so on. So now that we have a clear understanding of the historical context of race and racism, it's important for us to have these three understandings of different types of racism. We have institutional racism, internalized racism, and interpersonal racism. And again, in the talk in February, I'll go into more detail about these. For now, I'll be focusing on the interpersonal racism component. So with personally mediated racism, this is the one that we're most familiar with. And this is the one where we have a very clear understanding of explicit. For example, these are very overt, very conscious, aware, easily to report. Now contrast that to the implicit, which is the unconscious, typically unknown, involuntary form. So in order for us to really address this type of more difficult, more subtle forms of discrimination in the work environment, in the teaching hospital, or in the clinic setting, we must be aware of how we ourselves play a role in this. So this goes on to the second objective, which is recognizing microaggressions. So it's important for us to acknowledge the fact that most of us, including people in positions of power like many of you here, alternate between being the recipient of a microaggression and actually committing a microaggression. So in brief, microaggressions were first introduced in the 1970s by a Harvard professor named Dr. Pierce, and he described them as a subtle, stunning, and often autonomic and nonverbal exchange. And it's an act that infringes on a person's time and space and energy. And he really used this concept to identify the different forms of more subtle discrimination that were very different from the Jim Crow era. So fast forward to a more recent definition provided by Professor Su, where he says that it goes beyond black-white interactions, and that they're phenomena that can occur on a daily basis. They can be verbal, behavioral, or environmental, and it's derogatory, negative, and typically have racial slights. Now, in my work more recently, I try to emphasize that microaggressions are a modern form of subtle exclusion rather than modern forms of racism, to emphasize and remind us that microaggressions go beyond race. There is both established and emerging literature that show that microaggressions extend into other socially constructed identities that embody privilege in different ways, such as income, ability, social capital, religion, sex and sexual orientation, for example. So microaggressions are very complex and very challenging to identify, to examine, and even to confront. So as a trainee or as an attending, it's important for you to really keep in mind that these are very difficult topics to discuss. There might be some discomfort when a trainee or a colleague comes to you and addresses this topic. It's important for you to be able to sit with that discomfort and to be able to really process it. And again, we'll talk a little bit more about that in a bit. So to give a few more examples of what microaggressions are, it's important to really understand, first and foremost, that microaggressions is not about having your feelings hurt. It's about the negative impact that being repeatedly insulted, invalidated, alienated, dismissed, and how that reinforces power, privilege, and racism and hierarchy within our institutions. And it's also how microaggressions can negatively impact a learning environment in your institution. So medical institutions can create an environment that either facilitates or curbs these subtle forms of discrimination. Now, let me give you a few examples of what it's like when a medical institution, in one way or another, fails to have a culture of awareness and of accountability for microaggressions. So as a medical student, one of the most difficult microaggressions that I experienced and that led me to write one of my pieces in JAMA called My Name is Not Interpreter was the fact that one of my attendings during residency, during my surgery rotation, would summons me by interpreter. And so every morning when we would round, we would be in a large group and he would shout out interpreter, and I would have to run in front of the class and in front of the group and begin to interpret for the surgeon in front of my colleagues. Now this happened repeatedly. At that point, I didn't have the power as a medical student or the comfort to really confront my attending about this, and I feared the repercussions this would have if I were to bring it up to anyone in terms of my potential grade in that rotation. And this type of instance would leave me constantly wondering, am I ever going to be good enough? Will things ever change? So it's important to note, again, that microaggressions reinforce otherness and power differentials. Now, keeping in mind the fact that microaggressions can vary tremendously by the individual and their prior history is important as an educator. Microaggressions can be viewed as invalidating statements. So you are another, as I previously discussed with immigration patterns. The recipients are typically marginalized, and because of their backgrounds, they're made to feel not part of the medical team. And they happen over and over during the training, and an accumulation of these statements can have negative consequences. Now, earlier there was a question about, are there any biological markers in terms of chronic stress? The next slide, in a few slides, I will address this. Now, in preliminary research that I was conducting looking at microaggression experiences throughout the US, there were many other trainees that were commenting on their own experiences at different institutions that range from female medical trainees being confused for the nurse to individuals, other trainees of color who would consistently get confused to be part of the cleaning staff, housekeeping, other roles that went beyond their medical student role. And again, this is not about getting your feelings hurt. It's about the impact this has on maintaining power and privilege and othering the students. Consistently experiencing this can have its biological toll. So the studies in front of you here have started looking at the effects that chronic stress of perceived discrimination have on the body. And we can see that it ranges from chronic low-grade inflammation with increase in interleukin-6, TNF, leading to coronary artery disease, to shortened telomere length in African-American men who report higher perceived discrimination and premature cell aging. So the impact on our biology and individuals' biology is something to keep in mind, and the research here is definitely improving. So why is it that it's so difficult for individuals to really talk about this and acknowledge their role in perpetuating microaggressions? Why is it that specifically white individuals have a difficult time talking about this? So after my piece in JAMA was published, I received quite a few emails that I'd like to share with you now. In response to my JAMA piece, here's you have a Spanish first name and you acknowledge a Mexican accent. Why would they not think you're a foreigner? And why is it that their problem and not yours? Another email said, if you were called to be an interpreter, how about saying, great, glad to help. I'm Dr. Montenegro, grew up in LA, and I'm proud to be bilingual. Another reader wrote, you have to change you and your response to these things. All the paper on microaggressions are not going to change things. Anger is not the answer. So some stranger says something ignorant. What of it? Why should I care? Why not lighten up? I never even considered working up a fence over anything that was not meant to offend. Younger people these days, they're so lucky they have to imagine they're hurt. The last one, you're in medicine now, toughen up. What explains these reactions? White fragility. So Dr. D'Angelo, a white woman herself and a researcher of white studies, has coined the term white fragility to explain these types of reactions that people have when discussing racism. So in her book, What Does It Mean to Be White? Developing White Racial Literacy, she goes into great detail. I highly recommend that book. So our third objective is understanding white fragility. And I like summarizing her white fragility by sharing this quote. She says, white fragility is a state in which even a minimum amount of racial stress becomes intolerable, triggering a range of defensive moves. These moves include the outward display of emotions such as anger, fear, guilt, behaviors such as argumentation, silence, and leaving the stress-inducing situation. She goes on to explain, we experience a challenge to our racial worldview as a challenge to our very identities as good, moral people. It also challenges our sense of rightful place in the hierarchy. Thus, we perceive any attempt to connect us to the system of racism as a very unsettling and unfair moral offense. Now, we need to be able to talk about discrimination and acknowledge how we play a role in perpetuating this problem. And I argue that an institutional culture of silence is an institutional culture of complacency. Now, for the fourth objective, applying practical strategies for responding to and coping with microaggressions, both at the individual and institutional levels, I will unfortunately have to leave you with a cliffhanger there and encourage you to attend the February meeting, since this is also pretty time-consuming and merits quite a bit of attention. I can end by saying that overall, it's important in addressing racism, microaggressions in your institution by acknowledging the role that you play with perpetuating racism, by being aware and comfortable with your own white fragility, if that applies to you, and being able to come up with a healthy way of discussing and addressing these issues for your trainees. So with that, I'd like to end for now and leave some time for questions. Thank you.
Thank you so much. That was really, really powerful, and wow, leaves me wanting more because there's so much to cover there. I'd like to encourage our audience to submit any questions they have for Dr. Montenegro in the time that we have left. I'm sure he'd be glad to answer specific questions about the content of this session, whether that's about either pieces that he hasn't yet tackled or elements that he did cover in the talk about the experience of microaggressions, or kind of how to tackle the issues of dealing with this in the medical workplace specifically. Let's see, we'll kind of give it a second for those to come in. What is the what are some of the kind of things that I can't help myself? I have to ask, like, are there certain things? Do you feel like that that the place to start is perhaps awareness? What would you say is perhaps a starting point for addressing some of these issues in the medical workplace?
I think we generally start with awareness. One of the fears I have is that many institutions believe that just by having a talk on awareness definitions and examples, that it's enough. And really the literature showing on how to change bias talks about going beyond awareness to also implementing practice of changes for cognitive biases. So there are some curriculum that's evidence-based that's being developed on how to change cognitive biases that ultimately affect the way that we interact with individuals.
Interesting.
So
yeah,
but there's a lot more after that.
That makes sense. It's not just as simple as being aware. That makes absolute sense. I thought it was fascinating the tie-in between the biological markers that you had in that slide and just the amount of evidence that's coming out about the effects of chronic stress. That it seems like there's kind of a cascade of studies coming out in recent years about the effects of chronic stress and how that particularly impacts people of underrepresented and underserved backgrounds, particularly.
That's right. over the past 2 years, there's been quite a surge in that.
Yeah, absolutely. We are coming up against the hour. I would love to, if anyone has questions that they'd like to send to me, I can pass them on to Dr. Montenegro. If you wanted to, Dr. Montenegro, if you want to pass the slides over to me just real briefly, if you want to change presenters, I'll kind of take that over here. Just briefly to tell everyone just to don't forget that you can get all of your questions answered. Perhaps not, but do keep in mind that the STFM Conference on Medical Student Education is coming up next year, January 31st through February 3rd, 2019. So registration is now open. It'll be in Jacksonville, Florida, and we've got quite the conference lined up for you. So we're excited to bring a lot of good content to you, and we're excited to hear the rest of Dr. Montenegro's speech there without a doubt. A good conference lined up as always, and registration is now open for that. So feel free to go to the STFM website and take a look at all the information that we have there. We are so thankful for all of you who attended, and I'm very, very glad to have had Dr. Catherine Florio Pipas and Dr. Montenegro attend this and give snapshots and brief highlights of both of their presentations from the 2018 conference to the 2019 conference. So I just can't thank you all enough for attending today, and thank you to our presenters. All right. Oh, and I want to also let you all know I will be sending a post-webinar survey. We're so glad to have you here, and we want to know just a little bit more about you and what you learned in this presentation and what you'd like to hear more of. So keep an eye out in your inboxes for a survey from STFM for this. So thank you both, to Dr. Pipas and Dr. Montenegro.
Thank you for having me.
All right. Have a great day, everyone.